I have been talking a lot lately about the idea of model mismatch in therapy. And what it really pertains to is this idea that not all therapy is accessible. I think as clinicians, we're trained in evidence-based practices and gold standards and in certain modalities, and then we bring a client into that treatment assuming that it's meant for all neurotypes and all individuals. And that's just not the case. Not all therapies are universally accessible. So model mismatch is really this idea that, we could have a therapy and we could have a client. And if the therapy does not match with the client's neurotype, the actual therapy is not going to be accessible. Why this is important is I think as clinicians or treatment centers, sometimes there's this push to force a client to adapt to the therapy, but we don't often get trained in how to adapt a therapy to a client. I think there's a lot of ramifications if we don't do that. An example being, someone may not be comfortable with, an open-ended, free-flowing, kind of ambiguous structured therapy. So if you were to ask them an open-ended curiosity question, they may respond with, I don't know. And it looks like avoidance, shutdown, not engaged, not motivated, but maybe the reality is that their brain needs more structure, more containment in order to have safety to kind of process and move through things. Same thing with emotional recall. A lot of therapies will be like, what are you feeling now? What do you notice now? And kind of expect immediate access to verbal and emotional recall of their experience of a memory. Some brains, maybe there's a delayed emotional response. Maybe the memory recall is not linear. And if you're not taking that into account when you're conceptualizing and working with an individual, you're going to run into barriers. And a clinician who's not on the lookout for these things is going to make a lot of assumptions about a client's engagement in treatment. I like the idea of model mismatch in therapy because I think it takes the onus off of the client, and this assumption that it's all the client's problem or the client's issue if they're not engaging in therapy. It really makes us take a step back and think, hey, is this therapy accessible for their neurotype, for the person in the room? How can I pivot and change this therapy so that it's more easily accessed by the client? That's really what the idea of model mismatch in therapy teaches us. It's a bit of unlearning as a clinician. I think as clinicians, we are again trained in very manualized evidence-based practices, fidelity to the treatment, which is, all important, of course, but sometimes if that's not lined up with the neurotype or a processing style or a way of seeing and experiencing the world of the clients, the therapy is not going to work.